I'm half a proton guy and half a photon guy. About 50% of my working week I'm doing CT. This is easy. I'm not actually going to talk about MR thrombus imaging because I don't do it. And I reached out to some people and I didn't get much response. I don't think very many people are doing it, to be honest, these days. But anyway. This is also going to be easy because the man who wrote this editorial in radiology is sitting on the moderator panel. Venous imaging is actually difficult. It is really, really tricky. There's lots of problems with venous imaging. Invasive venography is hard to do, and you may not actually opacify the relevant veins, which is why he was talking about putting all these tourniquets on. Ultrasound is really good for veins, but only when you can actually see them, and a lot of the veins we're interested in, ultrasound can't see. CTV, as he says, it needs large doses. He said as much as possible contrast, didn't he? He said as much as possible. And CT is much less sensitive to iodine contrast than MR is to GAD contrast, which is why his images looked so actually really bad, didn't they? They looked really bad, didn't they? Conventional venography was thought the gold standard. It's one of these very tarnished gold standards because no one really knows. It's kind of specific, but you're looking for an absence of something, and we don't really know how sensitive it is. We don't know how sensitive venography is. And this is venography. This is the best way to do lower limb venography. You put a needle into the bone and you inject into the bone. Would you like that done to you? No. If you've got a DVT and a swollen leg, it's not easy to do proper venography into the vein even. So it's not a nice and easy technique. This is one of the last conventional venograms I ever did. Can you spot the DVT in the audience? Can you see it? How extensive is the DVT? How do you follow up this DVT and tell whether it gets better or not? Very difficult. The other thing with venography is you can cause deep venous thrombosis. There are studies in the literature that say that doing the test, about 15 to 20% of your patients, after you've injected contrast into the veins, they will get a DVT. So that's not a good idea either. And while you're injecting contrast into the veins, if they've got a DVT, whoops, this might happen. Okay, so this has happened to colleagues of mine in the past. What's the advantage of MR? Basically, the advantage is it's really easy, and it doesn't need lots and lots of contrast, and it's quite quick, and we should be doing a lot more of it. And we shouldn't be doing it like this. This is a direct contrast-enhanced MRV, where we've injected dilute GAD contrast into the leg veins to try and show the iliac obstructions. And I don't recommend you do this, okay? So don't do this. It's back in the 90s. We do a lot of arteriography in the SMRA. This is arteriography, and we spend an awful lot of mental effort and R&D trying not to see the veins. We don't want to see the veins down here. We don't want to have our hospital branded as St. Elsewhere because we do such terrible angiography that we get veins that obscure the arteries. Yeah, so we spend a lot of time not doing it because actually seeing the veins is so easy. Having said that, seeing the veins is really, really useful. So this is a patient who's only got one leg and he doesn't want to lose the other leg, and he's too long to be recanalized across the knee with stents because that's never going to work. He needs a bypass graft. And at a glance, we can show the surgeon what to do with this patient because we just need to wait a little while, a minute or two, and then repeat the same imaging sequences, and suddenly we can see the veins, and we can see the great saphenous vein beautifully all the way down the leg, and at a glance, the surgeon knows that this is a good vein that he can use as a bypass conduit to save this man's residual leg. Which brings me to vein mapping. This is something that surgeons spend a lot of time and effort getting their sonographers to do prior to surgery. And it takes quite a long time, and they don't end up with a map like that. They use ultrasound, and it's about 40 minutes per leg to do it properly, and you get a typed report saying what the size of the veins are and where they are. Whereas this kind of thing just gives them an at-a-glance view. They can see the veins immediately. They know whether they're varicose. They know whether they're too big, too small, whether they don't go far enough. And we can use simple post-processing tools on CT. This is a CT workstation where you just put your venous into it, and you can curve planar reformat it. You can measure the vein. You can tell them the caliber of the vein all the way down. You can give them all these bits of information. And as I say, it's really, really easy to do because all you do is you just take another image at the end of your standard arteriographic MRA and you get all this extra information that the surgeons really do find useful, okay? They think this is useful, and we're often sitting in our MDT and they say, well, okay, we're going to have to bypass, show us the veins, is it any good? And it saves them having to send them off to another test, another lab. And this isn't high technology. This is just simple flash type stuff, maybe with some fat sat on it, whatever. It's not, you can do it on these are 11-year-old scanners, most of these images I'm showing you on. And as I say, these are bad veins, but you can tell that at a glance. You just look at it, you know they're bad. So we did a small study and we showed that it outperforms duplex. The map is more easily appreciated, and it's now our standard of care. So you've seen this before if you've come to the pre-conference workshop, in the fact that this is our standard lower limb MRA protocol. We do the standard lower limb MRA, we do the dynamic, we do the 3-station bolus chase, and then we do this, what we call extended phase, this high-resolution imaging just after the GAD's gone in. It's still swimming about in the vessels. You don't have to do anything fancy, and you're only using a total of your usual GAD dose. So here's a patient. He's got bilateral obstructive disease, but he's disproportionately symptomatic on the left side, and it's difficult to tell from this why is one side so much worse than the other symptomatically. Well, if you do this kind of imaging, then you suddenly find out why, and you find out because he's actually got bilateral DVT, but on the right side it's limited to the calf. On the left side it goes all the way up to the common femoral vein and off into the pelvis. So he's presenting with what you think is an arterial problem, but his insufficiency is both arterial and venous, and the venous is much, much worse on the left. And we find about 5–10% of our critical ischemic patients have incidental DVT. It's not always incidental though, because obviously these patients are prone to DVT, they're prothrombotic, they're not walking around very much. Here's a patient came in with a critical ischemia. If we'd done conventional CT or invasive arteriography, we wouldn't have got the diagnosis on this patient, because although we can see that this leg here has been trashed on the left side, that's not the end of the diagnosis, because he's got clean arteries elsewhere. And when we look at the venous imaging in this patient, we suddenly see that he's got DVT, extensive DVT in the left leg here, going all the way up through the popliteal vein, up into his duplicated femoral vein, and right up here to the common femoral vein. We can reformat that any way we want. We can show it coronal. These are isotropic things. As I say, this is an 11-year-old scanner that's produced this. So he's got paradoxical embolism. The DVT came first. It then went off to the heart, swirled around, and then came back down the same leg. Why it went down the same leg, didn't go to his brain, I don't know. But this could have been stroke, okay? But we only make the diagnosis by looking at the veins. And if you don't look at the veins, you don't make the diagnosis. We've been talking about the lower limb veins. We think the lower limb veins are easy. The anatomy is easy. But in fact, lower limb vein anatomy is actually quite complicated. And since we're in France, before I move on to that, actually, one thing. We must call it the femoral vein. Never call it the superficial femoral vein. Please do not call this the superficial femoral vein. It's the femoral vein. This is a French paper from 2010. It's really, really interesting. It's changed my ideas about the lower leg. I've been doing imaging of the legs and veins for years and years and years, and I never appreciated that I wasn't seeing the anatomy. You know, when I was doing ultrasound, I'd come down to the adductor canal and think, where's the vein gone? Oh, it's just a bit deep. You know, I can't see that bit. I'll go and look behind the knee. But in fact, the reason is there's a lot of people out there have got really different anatomy of the veins of the leg. This is the standard anatomy, unitruncular modal anatomy. But there's a bunch of us in this room. There will be people in this room who have this kind of axiofemoral unitruncular or maybe bitruncular anatomy. So I just went through 200 consecutive MRs from our institution from January to June this year and looked through it. And I found roughly the same amount. This was a cadaver study done by anatomists where they injected cadavers to find this. But we found really basically the same incidence of these variant anatomies. And you can see these beautifully just on these standard MR images, these kind of duplicated femoral veins. Okay, so these are the kind of images we're getting. This is just a standard T1 flash with a 0.7mm isotropic resolution, just run at the end of an MR examination, and you get all this information absolutely for free, and you can see exactly where the veins are, where they branch, where they go. Okay, so here's an axiofemoral. Just keep your eye on this fellow here, okay? So this is, it looks like a duplicated popliteal vein. But if you come down, see him here? So he's going a different way. This is a potential bypass. You know, if this man had had his great saphenous vein stripped, you could potentially take that out because it's an accessory vein that you can use in surgery potentially. And you can see it at a glance. You know, the overview MIP, you can see what's going on. Of course, in renal donors, we didn't really get above the pelvis with the previous speaker. All my renal donors, we have to look at the veins just as much as we look at the arteries. The arteries here for the left kidney are entirely suitable for donation. But this retroaortic renal vein with all the connection to the lumbar veins is certainly not suitable for donating that kidney. Okay? So this rules this patient out from renal donation. Vascular malformations, I get asked to do a lot of vascular malformations. These are low flow. You won't see these on venography, you won't see them on CT. Ultrasound doesn't characterize them well, particularly if they're involving muscle or bone. Okay, so MR is absolutely ideal for these. This is years old, this is about 20 years old. This is a venous enhanced subtraction technique when we've taken a peak arterial from a steady state phase, we've got only the veins. We can do that now with ferumoxetol. We can do first pass with ferumoxetol to get arterial only, we then get arterial and venous, and if we want to just show the veins, we just take one from the other and we get pure venous, if that's what someone wants to see. And of course, if you want to spend time on a workstation, poor Finn gave me these, he spends obviously too much time in the dark with a vitreal workstation. Here's a patient with an occluded SVC. You cannot really show this with CT. I mean, you know, you can do stuff like this with CT, but it's really quite difficult to do this, whereas MR, big field of view, you can do this quite easily, show all the collaterals, show where you can do something. Here's a really common problem again, people don't do enough of this. This is a 23-year-old woman with recurrent headache, opening pressure of 29 millimeters of mercury, do a CTV. No, don't do a CTV, she's young, okay? Do an MR. This on an 11-year-old scanner is a 4-minute examination total. We give GAD, we do a 3D T1 head. That's it, on and off the scanner, okay? And we can see this is not a normal pituitary for a 23-year-old girl. This should be convex, okay? So we've got signs of raised CSF pressures, which confirms the clinical scenario. The sagittal sinus, as we saw there, was widely open. But if we look around here, look at this. Bilateral sigmoid transverse junction sinus stenosis, okay? So she's got pseudotumor cerebri, due to venous drainage outlook problem from the head. And you can see this with CT, but I find it's really quite difficult because the contrast next to the bone is really difficult to see, whereas MR, you just put a thin sliding MIP on it and it's really easy to see. It's a simple diagnosis, it's a quick diagnosis, and it's a game changer for these patients. The Society of Magnetic Resonance Angiography. Angiography, yes, I think that's what we're here for, angiography. It's not the Society of Arteriography, okay? It's the angiography is arteries and veins, and I would like to promote the fact that every time we look at arteries, we should be looking at veins as well, because it's really easy, it's not difficult, it's not rocket science, and it allows us to now see veins that are otherwise invisible. All these axiofemoral trunks and duplicate and deep femoral trunks and stuff, these variants of the lower limb veins, we never saw them with conventional venography because we didn't know where the veins that we were seeing actually were. We didn't know whether there was a DVT hiding there because they weren't opacified. The patient went away with a swollen leg and we said there was no DVT because the normal ones were all open, but we didn't know that the abnormal ones were stuffed full of clot. Quick and cheap, and it adds value. Thank you very much.